Hi, this is Dr. A with your second video on IT and its impact on healthcare. This is Chapter 10 of the 5th edition of Basics of the U.S. Healthcare System, and we are in our Intro to U.S. Healthcare class. Okay, so for this one, we're going to talk a little bit about artificial intelligence and clinical decision support systems. So artificial intelligence is a field of computerized methods and technology that are created to imitate human decision making. One of the techniques of AI that's used in healthcare is expert system, these systems were developed to imitate experts' knowledge in decision making. And so there are different ways that AI modules or AI programs can be done or run. So one can be, for example, you feed her information. So let's say you want it to read images for in radiology. You can feed it like normal images, and then you can feed it some of the abnormal ones that are already linked to different conditions. This is what pneumonia looks like. This is what a large heart looks like, and all of the things. And for some very specific conditions, and you have to feed it thousands and thousands of images. And then, so it learns on those things, and then you give a set of testing it and just giving them images and see if it can interpret them correctly. So that's just an example of AI systems. There are some systems where you just feed it a bunch of data and let it find the relationships itself, but sometimes, and if you add more data into the set, the relationships aren't predictable anymore. It can find other relationships. So it is definitely a very neat, growing segment of healthcare, and it's here to stay. The clinical decision support systems are systems that are designed to integrate the medical information, patient information, and then a decision-making tool, which is an AI tool, to generation information to assist with the cases. So maybe it sees that with every patient that presents with these sets of symptoms, all of these labs are ordered, and maybe the physician missed a lab or two to order, so maybe it would suggest this, hey, did you forget to get blood cultures, or don't you need a lactic acid level or something like that, or shouldn't you give this type of medication? And so it can assist, remind, and do things like that with the cases. So expert systems can be used to alert and remind healthcare providers of a change in a patient's condition, or to have a laboratory test or an intervention performed. So again, shouldn't you do this follow-up test because this result is this way, or this patient's previous lab was this, or the previous level, so now it's this, so there's a change there, even if it's just in the vital signs or something like that. So it can help, and these are helpful because physicians can often work long shifts. If they're working at ER, sometimes they can work 24-hour shifts. They can have decision fatigue. They can be, tired, especially if they're, on the 20th hour of a 24-hour shift, and they could miss simple things. So it can even assist with a diagnosis using the system's database, kind of pulling all the information and suggests some diagnoses for the physician to consider. Expert systems can also expose weaknesses in a treatment plan or check for drug interactions and allergies. It looks for it without the physician having to go back and look to see if there were any allergies to what they have prescribed. A weakness in a treatment be something maybe that's missing, or something that's not according to normal guidelines maybe. And they can interpret imaging tests to flag any abnormalities. So this is done more and more. This is where I feel like one of the fields are medical imaging careers, radiology careers, are using a lot of AI to help screen through all of these CTs and MRIs, and yes, radiologists can look at it, but the AI systems can look at them first and flag things. And then they can be reviewed by an expert and confirmed. So the more complex duties of a system, though, an expert system requires it to integrate all this information then with pulling the information from an EMR or an EHR system, so it can interface with the patient data and pull it all together for the patient. So some legal and ethical issues around some of this IT stuff with the electronic health records and even the AI tools, etc., is that what happens is technology just forges forward, just keeps going, right? Keeps going. But the regulations often lag behind the implementation. So one of the legal barriers is the sharing of patient information electronically with other providers or within systems and networks, right? Does that violate HIPAA regulations pertaining to privacy and confidentiality? Because oftentimes this information can be shared without your knowledge. But at the same time, do you have to consent to all of this sharing of information each time it's shared, electronically shared? Because that would be a lot of, again, decision fatigue, where you'd have to just click, yes, all the time, and you'd be getting notifications maybe on your phone all the time, and it would be really annoying. And so, like, what can be assumed that a patient would want shared, not want shared? Some of that data could be also sometimes de-identified. It kind of all depends on how we're looking at it. So now let's look at clinical decision support systems. So the first one of those is the computerized physician order entry. It enables a patient's provider, so a physician, a nurse practitioner, or whoever, maybe a physician assistant, to enter a prescription order or to order a lab or a diagnostic test like an X-ray or MRI, and they can order it into the computer system. So the advantage of this, you have to think of what it replaces. So it replaces the chart ordering where the physician wrote all the tests that they wanted and just handed it to the secretary, and then she had to decipher his or her writing and sometimes might get some tests confused. Well, here at least the physician can look through the system and click on the tests and the orders that the physician wants, assuming they know how to use the system and they're not themselves confused between a couple of tests, because there are some tests that can be confusing because there could be several of the same kind, and to make sure that they're ordering the right one. And the order entry has 4 components. So when a physician orders a lab test or a diagnostic or a prescription, first the information can be entered by the physician from either a handheld device, a laptop, or a desktop computer. Then the provider, so the physician themselves, can order a test, a prescription, or a procedure. It is then connected to a decision support system that alerts the provider with their orders, see if it's something maybe appropriate, not appropriate for that condition, or if they've already ordered it, or if it's a duplicate test or something like that. And then it can also be integrated into the overall computer system of the organization, so it makes it into the EHR or the EMR. So another, a sub-branch of the computerized physician order entry is e-prescribing. So it focuses on electronic prescription ordering by a provider for their patients. This helps with patient safety because it seeks to address problems that can arise in medication ordering and administration because of drugs with similar sounding names, similar dosages, or similar labeling. So again, with the person, instead of just writing it down, one person writing it down, the other one trying to interpret it, at least a physician ordering usually knows what they want and they can pick the right medication and dosage that they want. Over 90% of pharmacies accept electronic prescriptions. So again, it should be 100%, and we're getting there, but this is a very big advantage. Also, prescription pads aren't needed in that way, so then they can't be stolen or faked or something like that. The prescription goes directly where the patient wants the medication filled. So again, e-prescribing can be performed on a desktop computer, a laptop, or a handheld device that records the physician's prescription, which then eliminates the need for an individual to read a handwritten prescription. And so that's one of the items that really increases the safety for the patients. Section 132 of the Medicare Improvement for Patients and Providers Act of 2008 authorized incentives to encourage the physicians to e-prescribe. So in January 2009, then Medicare and some private healthcare plans began paying a bonus to physicians who e-prescribe to their Medicare patients because it was safer and easier to track and all the things. Since 2012, Medicare has also penalized physicians who do not e-prescribe by reducing their reimbursement rates by 1%, then 1.5%. That was for 2013, and then 2% for 2014 and all subsequent years. So they keep diminishing their reimbursement rates if they don't use e-prescription. So also one of the good things with e-prescription is, again, everything can be tracked. So you can see if the physician sends the prescription over to the pharmacy, and if the patient doesn't pick it up, doesn't fill it. So that's something that can be seen, whereas with a paper, once you've released that paper into the world, you really don't ever know, what if they went to a different pharmacy than they're used to, they were out of town, and so it's more difficult to see if they actually at least fill the prescription. So let's talk a little bit about pharmacy benefit managers. They are there, they exist. A lot of people don't know that they are working in the background, but these are companies that administer drug benefits for employers and health insurance carriers. So they contract with managed care organizations, self-insured employees, Medicare and Medicaid, managed care plans, federal health insurance programs, local governmental organizations, health insurance companies, and they contract with them, and then also with pharmaceutical companies. So much so that approximately 95% of all patients with drug coverage receive benefits through a pharmacy benefit manager. You just, they're there, you just don't know they exist. They manage approximately 70% of more than 3 billion prescriptions in the United States each year. This is especially true for medications that a patient would have to be on regularly, taken every day, day in, day out for years on end. There are 30 pharmacy benefit manager companies. In 2021, the top PBMs, including CVS Health, Express Scripts, and Optum Rx. CVS Health's market share is over 30%. The PBM integrates medical and pharmacy data of the population to determine then which interventions are the most cost-effective and clinically appropriate for those patients. Again, so they can save money. And there's been some controversy called spread pricing, where the PBMs are reimbursed at a higher rate for generic drugs than what the PBM actually pay for from the pharmacy. So they're able to get some little extra money there and make some money off of that. So next we have drug-drug interactions. So these are used by software programs to alert pharmacists and clinicians about potential drug-drug interactions. These alerts can notify the provider that two drugs may interact, or that there may be management strategies provided regarding these drug-drug interactions. So like what timing to use, how to separate, so sometimes it's not so much that you can't take both drugs, as that you just don't need to take them at the same time. Or maybe suggest an alternate drug that could work just as well. And some of these also will work with supplements and other things the patient might take. So to manage a lot of this information, we need these health information exchanges and regional health information organizations. So health information exchanges were developed as a single source platform to collect, store, and share data that can be used by health providers to make informed decisions. They can collect data from different patient care sources, so pharmacy, imaging, clinics, hospitals, etc., and they collect all of that and then extract more comprehensive patient information to make more informed care decisions, to see how patients are moving in the system, where are they going, how often do they go to the clinic, do they get admitted, how long do they stay. There's so much data that's being generated all the time. These health information exchanges can help kind of integrate all of these things. They are the foundation of data-driven patient care because it can provide the ability of this interoperability among patient systems to integrate their data. Again, the pharmacy system talking to the outpatient surgery system, talking to the hospital, talking to the clinic, just all the providers, everything being linked in the network. Whereas it used to be, they were all separate silos, separate entities that didn't talk to each other. So then we have regional health information organizations. These are a group of organizations that are funded by the federal government, that are within a certain geographic area, and they share health data electronically, typically from EHRs and EMR systems, and we're often a depository for these health information exchanges integrated data. So they're a little bit larger, like a regional thing. And so in 2021, 9 states form a consortium for state and regional interoperability with the goal of improving population health nationally. So the ultimate goal would be that it wouldn't matter where you went in the U.S. For example, I was at a conference in Pittsburgh a couple weeks ago, and if I had been ill there and had to go to the hospital or to a clinic, it would have been great if they could have just accessed my patient record, back home, and just had, they could just pull all of it up without me having to fill out a bunch of paperwork and answer a bunch of questions. And so we're growing this right now by region, but the idea is eventually we'll have it all nationally where it's all integrated and your data could be accessed if you're elsewhere. So, so this is a start, but this nonprofit consortium connects over 80 million patient records across several states with the intent of providing services to healthcare organizations. So let's talk a little bit about blockchain technology. So it is a system for recording and storing transaction records, which are then distributed across all the participants who are sending the data. The COVID-19 pandemic impacted the supply chain operation in all industries, including healthcare. During the pandemic, healthcare organizations were struggling to find supplies and equipment for the front line. The Trust Your Supplier network, using blockchain technology, enabled these types of suppliers to easily connect to the healthcare industry to provide the needed supplies. And so what you need is like real-time data of what was where. So blockchain technology works in a way that, for example, a Google Doc works. So if you're working on a class project and you have 3 classmates and you're all working on this one project, you can each make contributions to the Google Doc, and you can see in real time who's typing and who's adding stuff, who's done what in that. And if you can even work on it at the same time. So one person being in a document does not lock all the other ones out. So it used to be that's how computer systems were. Like if you were in a chart making notes, the doctor was in a chart making notes, the nurse couldn't get in and add notes to it. But with blockchain technology, you can have simultaneously things going on, being entered by different people and different computers, all going into the same patient record without it causing any kind of problem. So you always have real-time updates. Okay, lastly, we're going to talk about IBM Watson. So it was created in 2006. It is a computer that was originally built with a host of AI tools. So in 2011, then, the creators decided that a way to test its AI was to compete against the 2 greatest champions of Jeopardy, and the machine beat both champions. So IBM then created Watson Health, which provides health analytics consulting for health organizations. Their focus are genomics and oncology, improving medical imaging, life sciences, value-based care, and patient-centered care. So it helps to bring up, if you want to bring AI tools into your healthcare practice, Watson Health might be one of the places to go to see to make it work. And they also are really concerned with cybersecurity and stuff. But after billions of dollars in investments, IBM sold Watson, or IBM Watson, to a private equity firm called Francisco Partners. An analysis of the failure indicated that their cancer diagnostic tool was not developed using actual cancer data, but hypothetical data developed by a group of physicians, and so that was a flaw in the system. So this really highlights some of the weaknesses of AI, because it is really only as good as the information you feed it to learn on. So if it learns on crap information, the AI system is not going to work really well. So anyway, sorry, that was kind of the end. But I have checked some of the IBM Watson stuff like recently, although it was last year, and they were like also into cybersecurity and things like that. So again, this is just this is a problem just with AI, and it doesn't have to be just from IBM. Just, you have to know that AI is only as good as the training it gets, if it's the training tools, and if it's a self-learning one where you just feed it a bunch of data and you ask it to find relationships, it can be really weird what it finds because it has no metrics, like no things to go by. And if you add more data to it, again, the relationships can change completely. And so it's definitely quite a complex topic, but it's really worth looking into. So we have one more lesson coming up on IT. I'll see you there.